Good afternoon. Thank you very much to the organizers and Dr. Sinha for inviting me here. I'll be covering a little bit few basic cases and some of my cases to share with you people to see how can I stop it? Sorry. Where is that? How can I stop it? I want to stop it. Good. So, see, what is the basic part of the pediatric cataract surgery? We all expect that we should have a very clear anterior capsule, and we can do an anterior capsulotomy and taking out all the loose cortical matters, and then doing a posterior capsulotomy with anterior vitrectomy and putting a lens with or without. But many a times it really not so. There are many other cases that we come across, and every time when we really plan to do cases like that, we have to think in advance that what we are going to get. And if we don't have a very sympathetic mind before we think that what we are going to do in these children, so that these children is going to live for long. So what is the aim of a surgery, pediatric cataract surgery? It is that having a very clear visual axis, and so that this child can have very clear and very optimal vision. See, this is a extra membrane over the anterior capsule. If you really think, if you give a little thought and have a very clear look, that this membrane can be removed before you do this anterior capsulotomy, and then you can really finish it. But you have to think that something might be wrong over the anterior capsule and look at very carefully. When you see that, yes, very tough and fibrous anterior capsule, and how this can be removed. A very regular anterior capsulotomy is not be possible here, and a vitrectomy cutter probe can be used to take this very round anterior capsulotomy using this cutter instrument, so that the beginner can really have a very nice anterior capsulotomy, and the integrity of the anterior capsulotomy age should be really preserved, so that you can use this bag in future, putting a lens into the bag, and so the lens can be really placed into the bag very safely. But other techniques are as well. When you have also a fibrotic anterior capsule like this, you can use scissor. You can use the straight scissor from different angle, 4 different angle, to take this fibrotic anterior capsule out. But on the other hand, you can also use this curved scissor to take your fibrotic anterior capsule. And also, if you like, you can enlarge your capsulotomy opening with your vitrectomy cutter, as it was shown before, and then you can use it. So integrity of the anterior capsule is very important. But there are many cases where the intralenticular pressure is really, really high. Whenever you touch the anterior capsule, it really extends, and you can have an Argentine flag sign. But how you can really stop it and how you can really handle it. Even see here, I was about to do an anterior capsulotomy, but whenever it was about an age, it was running through to the age. I tried to take this loose cortical matter taking out from the bag, but you see it extends right to the periphery. So now what I have changed my style, my technique, to have a very small anterior capsulotomy opening, so that you can take all the loose cortical matter out from the bag, and then you can extend as you desire what are the size of the anterior capsule you want to have in your operating field. But important point is that, because there is some sort of cortical matter there, your illumination and magnification should be very good, so that it doesn't go very periphery. Other technique is you can just insert a needle, a 26 gauge needle, and take all the cortical matter out from the bag, and decompression is there, so that you can have a very flat anterior chamber, and afterward, just similarly, you can complete your anterior capsulotomy comfortably. And every time, whenever you get a case under the microscope, you see every cases are a little bit different from your previous cases. So whenever you have this under the microscope, you might need to think how you're going to end up this case. This is a traumatic cataract. So cornea was repaired before. Extra membrane was over the anterior capsule. Part of the anterior capsule capsulotomy was being done with the capsulotomy forceps, but the other part was so fibrotic, it could not be really removed. It could not be completed with the capsulotomy forceps. So this curved scissor was again used. And this curved scissor is a very small, helpful tool for me. And you see, this is now the integrity was there. And you can put a lens into the bag. And then you complete your posterior capsulotomy, and also anterior phase of the vitrectomy was done. And this was another traumatic case. There was a corneal opacity where pupil was not dilated at all. So this Irish hook is a very useful tools in exposing the operating field in a patient like this. And if you need, you can use an extra hook. I had only 4 hooks, so I use a capsular hook as well. And this is another case where an microcornea and microphthalmos was there, and AC depth was so shallow that even manipulation with one instrument was very difficult. And there was no loose cortical matter. Anterior and posterior capsule was absolutely fused together. So I made a posterior capsule. I made a peripheral iridectomy through which under the iris I introduced this cutter instrument to take all the fused anterior and posterior capsule to make the visual axis clear for the child. And this is another traumatic case. This corneoscleral injury was repaired. Part of the capsule is deficient here, and vitreous was in the antechamber. So this management of the anterior capsulotomy is really, really important, and I didn't want to really disrupt this fibrotic membrane so that I could really place my lens afterward. See, here I caught this posterior capsule with the vitrectomy cutter. I use this vitrectomy cutter instrument for aspiration of the cortical matter, at the same time changing the mode to taking the vitreous. But the risk is there. You can really catch the posterior capsule, but you have to identify the case right away so that you don't really disrupt the clear visual axis. And with the help of keeping support of this fibrous band of the anterior capsule, the lens was put into the bag. Now, identifying of the pre-existing posterior capsular defect is very important in time. Otherwise, this might really extend. But even though, if you have a very meticulous vitrectomy along the edge of the posterior capsular defect, can really give you a space to put the lens into the bag like this. Now, this case was examined before in the outpatient department, but it was not really diagnosed that there are some zonular dehiscence was there. But on the table, it was found that yes, there's some sort of zonular dehiscence because of the trauma. So capsular tension ring was placed so that you can have a comfortable capsular bag to put your lens inside. And this is a PHPV case. There's so many PHPVs you can come across. But interestingly, this case, when the posterior plaque was removed, still there was a continuous bleeding. Vessel was deliberately delivering some sort of bleeding into the anterior chamber. And I had no other option but to take the advantage of the endocautery and to cauterize that point to have a very clear anterior chamber clearance. And this is my last case. This is a huge gap of the anterior and posterior capsule, and was not really sure whether to put a secondary lens into the sulcus. But with the help of the spatula, this spatula was really guided to place the upper haptic into the sulcus first, and then you play with the optic and very gently rotate the lower haptic into the sulcus. This spatula really gives a great help to put this lens into the sulcus so that these children all can have a very clear visual axis for the rest of the life with minimal complication as long as they live in this lovely world. With this, I really like to end my talk. Thank you very much.